consultant specialist in Sheila Hospital, Coimbatore. Dr. Anuradha Garu, Madam is the director of Anu Test Tube Baby, Hyderabad. Madam has done fellowship in Royal College of Obstetrics and Gynecology in London, UK. Welcome, ma'am. And I would like to request Dr. Sujata Ramakrishnan, HOD of Nova Fertility and Motherhood IVF, to the stage. I would like to request Dr. Swaminathan sir, Professor and Practice Senior Consultant on Clinical Embryologist, past, present days, and also our own Dr. Hitesh Bhatt, Medical Advisor. Since we have a short of time, we'll just quickly see what the panel discussion is very special for us, because wherever you go for a sessions, you will see gynecologists are having a panel discussion on their topic, doctors are having their own topic, scientists as embryologists, we will have our own topic. But the dialogue between the doctors, clinicians, and embryologists is very less. So we thought that we'll bring all of them to the stage, and we'll see how they are going to answer our basic questions for the same question how they answer. And Hindustan Times have reported around 27.5 million couples are actively seeking children and suffer from infertility. And worldwide, mid-2025, around 13 to 17 million ART babies have born already. This is the basic data, and we have got the data up to 2018. And you can see the last slide. Asia have more number of ART cycle practicing every year. And CNBC have reported currently 2 to 2.5 lakhs IVF cycle per year combined of only in India is happening, and they're expecting it may go up to 5 to 6 lakhs annually. And you can imagine how much ART centers are running, how many cycles they are doing in each cycle. This is a very big business now. They are expecting it goes up to 3.7 billions. So let us start with a basic question. So how do you want to start? Let's say you want to start a new fertility setup. What are the basic things you expect? Let's say a fellowship finished doctor or a gynecologist who want to start a IVF setup. What are the things they should go for it? What type of registration? Anybody can take a call. What are the basic steps? First step.
If you're going to start a fertility clinic, I think there are regulations about level 1. So you should have, like how Dr. Hitesh gave us the details about level 1, you should have a gynecologist in a fertility clinic, definitely. And then if you are just going to do ovulation induction and IUIs, then you must get, first of all, your clinic, when you're starting a fertility clinic, to be registered as level 1. And then the bare minimums that are required for the level 1 should be there in your clinic. Like what you have written here, the centrifuge, the ultrasound machine. You should also have your PNDT sorted out with the gynecologist who's going to be doing the scans. So all that has to be in order. And the other things, like, is laminar airflow a must in level 1? I don't know. I'm not sure.
It is not.
Is it, sir? Laminar airflow?
It is not must, ma'am.
It's not a must. So your centrifuge and your microscope and...
so what all we can perform in level 1? Restrictions? Anyone can.
See, level 1 is for IUI, that is what they have mentioned, but other things also can be done, like you can do diagnosis, you can do tests, you can do the basic investigations, and whatever your hospital is, suppose it's a laparoscopic surgeon or laparoscopic doctor is there, you can do even laparoscopy also. The license is required only for IUI. Rest all things you can do what a doctor can do.
What about level 2, sir?
The only concern is level 1, because earlier days they used to do the ovarian stimulation at level 1 and refer to level 2, which should not be done by level 1.
Okay.
So the stimulation should also be done by level 2.
No, there is no such law, madam.
No, there's no such rules that you can't stimulate in level
we
1.
have upcoming questions about that. So can we go to the what we need for level 2?
Level 2, you require all the facilities for ovum pickup, like all the machines, all the things, incubators and laminar flow and the nitrous and like all refrigerator, all these requirements they've given. Plus, you require basic embryologist and gynecologist, this and director. These 3 things are there. Anesthetist and even you can have, that is optional, they have said, the andrologist and the other staff you require. Also, as far as the
Sir,
other
as-
licenses are
Sir,
required.
as far as we know, according to the registration, andrology is must.
No, it is not must.
It
It
is-
is not must. It is optional.
So-
You may have on
So
call
there is-
somebody,
but the-
or you may not do that. You say that I am not doing any male fertility work. It is not compulsory.
So in particular state, they are particular asking urologist should be included.
See, that is what I am telling. The law, what it says is minimum this much should be there. Andrologist is not must. Even that circular was also there from the central government that andrologist is not required, because somebody may not be treating only male factor infertility. It is up to you what you are doing.
Sujata ma'am, what are the other equipments should be level 2 should be having?
See, everything like where so all equipment you need to handle the gametes and embryo you would require, starting from a laminar airflow with the stereozoom microscope, and then incubators, and minimum 2 incubators have to be there. So depending upon whatever your expected caseload is, you should have enough number of incubators. You should have a micro manipulator with inverted microscope, and then you should have all your cryo room, like a separate cryo room with laminar airflow again there, and a microscope there, and tanks. So these are the things which are necessary there. And you need to have a storeroom also to keep it's also mandatory to have this thing to keep your consumables and also to store your records.
Apart from what the Act has told, do you think something else has to be included in the law with your vast experience that when compared to Western countries, India should include these things into the law so that the practice becomes more refined?
I think, like we need to have some stringent requirement on air quality, because, we do not have a controlled this thing. So it is, I think, like how we are saying, a minimum requirement for the lab for air quality also, there should be a minimum requirement where we say not only HEPA, but then we also need to have this carbon filters. And I think this, if it is there, it is ideal.
About witnessing system, is it not, because whatever witnessing system, I think now at least the ART law is made and there is some regulations, but maybe after 5 years there should be still more strict regulations so that it will be better, or?
See, madam, law and quality are 2 different things. Law is something has to be fulfilled by everyone. Quality is something which takes you to the second level. It's like a small restaurant and 5-star restaurant has same license of restaurant. Now, whether it is 5-star or a small, that's a different issue. But the license required is a restaurant license from the health department. Similarly, small nursing home and corporate hospital will have Form C or nursing home license. So, law always gives a minimum requirement. Law can't give you maximum. Otherwise, you can't match up. They have to see at the lowermost person in the society, not the highest person in the society.
Okay, well said.
So what are the procedures can be carried out in level 2? I think
All these.
What?
Yeah.
procedures.
It's already listed.
It's already
already
listed.
said,
Yeah.
Answers are already there.
Yeah.
We are running short of time.
Yes.
So it's the do you
Yeah.
want us to read it?
Yes, ma'am.
Counseling of the couple. Definitely there should be a counselor who counsels the couple before they come in for the ART procedure and the alternatives given to them. There should be an ultrasound machine, and the PNDT ART Act should be there in place. Stimulation for OI plus TI.
Ovulation induction and timed
Yeah,
intercourse.
that is
IUI.
in level 1, I thought. Okay, in level 2, all that is included. So ovulation induction protocol should be there in place, and IUI protocols, as well as if what kind of IVF stimulation you are going to give, whether it is going to be a antac or an agonist protocol. Oocyte aspiration procedures are carried out in this level 2, of course, followed by IVF or ICSI as may be the indication. PGT, is it a must? I don't know. In all level 2, some have, some don't have, but if you have, it's good. So embryo biopsy PGT programs should be there. So you want
It
to
is
say
like-
something?
It can be carried out.
Embryo biopsy is you require PCP and NDT license. Embryo
Invasive
biopsy
license.
is
You
not
need to
something
endorse in
which is
your
by
PN.
default included in level 2.
So for surrogate embryo transfer, we need surrogate license also included. And apart from this surrogacy clinic, as we have discussed before, surrogate registration is must. And what about donor surrogate TT?
Donor?
Donor surrogate TT. Let's say one of the partners is donor, or can two partners go as a surrogate TT?
Not both. See, out of uterus, oocyte and sperm, one has to be of the couple. Right? So that is the simplest thing. And
So ART bank.
no donor stimulation you have written, that is nowhere in the law it is mentioned. It is all appropriate authority. See, stimulation anybody can do. You understand that?
But ART bank, can they stimulate donor, sir?
Anybody can, any MBBS doctor can stimulate. And ART bank is also having staff as MBBS doctor. So any doctor can give, even patient herself can take injection at home if she knows how to take.
But ART bank doesn't have any registration for a doctor or something like that. We have
For
level
stimulation,
2.
you don't require, see, what we are requiring registration for, ART procedure. What is ART procedure? To handle the gamete outside the human body and to put it back into the female genital tract. Now, as long as you are just stimulating it, you don't require that license. It is like one female, one girl, she was in the Mumbai, she was just at the seashore around 7 p.m. She started removing her clothes. One police officer was there. She came into two-piece bikini and about to dive in the sea. Now the police said, "Madam, you can't take bath after 7. So she said, "You should have told me." He said, "When I was removing the cloth." He said, "Madam, that is allowed." You understood? So what is allowed is up to this limit, it is allowed. You can't put it back into the system. As long as your intention is not to take or not to put, you are just stimulating, you can stimulate. Anybody can
So
stimulate.
ART bank can stimulate but cannot do egg collection and cannot put the
Anybody
embryos.
can stimulate. That is the only thing is, before stimulation, for ovum pickup, what you require is the form.
So for level 1, level 2, we need any gynecologist with some experience. But ART bank, there is no law is not saying we should have some clinician like that.
No, they say there should be a
ART bank must have
gynecologist.
RMP. One MBBS.
There should be a gynecologist.
One.
But according to the law, does it says gynecologist is important for ART bank? They don't say, I think.
See,
They say
if it
gynecologist.
Director should be there.
ART bank will have MBBS doctor. That is compulsory. Now, stimulation can be done by anybody. Any MBBS doctor can give injection. The only problem here is you have to fill form number 6 and form number 12 before stimulation. So those forms have to be filled at level 2. That is the thing. So if patient has to be stimulated or a donor has to be stimulated, anybody, donor has to fill form 13 before starting the stimulation. These forms belongs to level 2 clinic. So patient first must go to level 2 clinic, fill the form, and then patient can be stimulated anywhere. She can take injection at home also. If you give injection, she can take it herself. That is not the problem. Forms have to be filled in level 2 clinic.
Then who does the monitoring, sir, if the patient can stimulate
If it goes
themselves
to
at home?
OHSS and all.
That is what. See, she can get the monitoring done by anybody. For monitoring, you don't require any license or any permission.
What about picking up the red flags in this monitoring? If there is problems arising and you are an MBBS doctor who doesn't really know about control over
I
in
think it is-
hyperstimulation.
So that means gynecologist never creates OHSS, right?
No, there should be at
So
least a
that happens anywhere.
gynecologist.
So that is what I'm telling you. That happens anyway. You don't require license for the same. That is what I'm telling.
The ART level 2, where the Form 6 is assigned, they
Form
take
6
the
and Form 12 has
responsibility
to
of
be
that.
filled.
Yeah.
Has to be filled at level 2 clinic.
So they have to take responsibility of that patient, whatever happens. It's
The responsibility is always of the person who is doing it. By filling form, you can't take responsibility. Filling form is a procedure that has to be done. But responsibility is of the person who is doing it.
doing it. For example, level 2, they have come and enrolled, the donor has come and enrolled. Who takes the responsibility if something goes for the wrong for the donor? Does the ART bank take or the ART clinic takes?
See, responsibility is a very big word that is always of the person who is involved in the treatment, and there is no rule of thumb. So it is case to case basis. It is like if couple has infertility, who takes responsibility? It is case to case. It is not fixed that who is responsible. Husband is responsible, wife is responsible, both are responsible. That
Sir,
is
but-
case to case.
Sir, but you-
Similarly,
in your talk, you mentioned law is a law, regulation can or may not be, right? So
No.
if ART bank,
guideline is different. Law is
that's
law.
what. So, but ART bank, don't you think should have at least one gynec who have experience
That is
to
maximum.
monitor?
That is maximum. They can have MD or DM or FRCS. That is maximum.
But
Minimum the law requires is
Sir,
MBBS.
but practically from ART bank, when they stimulate and send the donor, they would send 40-50 follicles. If a clinician is stimulating a donor, she knows what happens if OHSS comes.
Now,
There,
now that I will answer. It is like, see, law
and
doesn't
sir, not only that, the quality of the
exactly. See, I will give you one example. Suppose you are at the airport, right? And somebody gives you luggage that take care of my luggage. There is no law which prevents you from taking that luggage.
It's your responsibility.
It is allowed. You can take anybody's luggage. But if the drugs comes out of it, then you are responsible. Similarly, if ART bank sends stimulated patient to you, there is no law which prevents you from doing that. But if something happens, you are party to that crime. Understand? So you have to be very sure from whom you are taking. But law specifically doesn't prevent you from doing that action.
Okay. Ms. Swetaram, you want to say?
So basically, it's very clear that law is different. Law comes with some clauses and numbers, and this thing you have to follow. But the person who is doing, if they are sensible, they will take the responsibility. That's the basic of medicine.
Okay.
So if you know the nitty-gritty and the penalties involved in the law, no sensible clinician will do stimulation just like that.
So
It's
we
very
have-
simple.
Okay, we have few. We'll wind up this in 1 minute. There are some delays in approvals, even if you apply for ART clinics. The law says 90 days or something, but I think some places it's not happening. Recently, we got a news in some Hindustan Times somewhere. Tamil Nadu have the most ART registered clinics than any other part of India. I don't think it's true. Maybe the people who have given the approval properly in Tamil Nadu, not in other places. So, what is your call on that, sir?
See, the problem here is that, state to state, there is a lots of variation. How the state government adopts the healthcare is entirely different. It is depending upon their hierarchy, the efficiency of the system itself. What basically Tamil Nadu did is that the people who are all having valid PCPNDT license, if they are running IVF center, they are not come for the inspection. They are given the license. But the new centers, they made it clear that they will come inspection, then only you will get the license. So it is very inconvenient. So the system already going, they are not disturbed. The new system, they are very particular. So number is less.
So, it is streamline, of course.
So that's why it is more of very systematic.
So, how long should we keep the physical documentation? Is there a
10 years.
10 years.
And then you don't have to destroy. You have to give it to the National Registry.
last question? Can we still take handwritten consents?
Consents are,
Handwritten consents.
consents are always written. It can be handwritten, leg written, mouth written. That is not a problem. It has to be written. So it can be, and it has to be physically signed. That is what is required.
So this is for basic ART setup. We'll make it very fast. So how do you choose location, design, and expertise of any new clinic? Location.
So gardener would say that it has to be in a place where there is less of traffic. And but that was 20 years ago. Now we are looking for places where there is more of footfall, meaning we want to have IVF center in malls where a lot of people keep coming. So like The location, I don't think it's not valid anymore. Only thing is, based on the location, you should have your center equipped with system where the air pollution would be less.
Okay. And
And probably not on the ground floor. Usually it is.
highest floor.
Yeah.
So highest floor. Why do you prefer highest floor, ma'am?
Depending on the money.
Why do you prefer highest floor? Any particular reason? So less VOCs, less pollution. Okay. So even recommendation saying
In
the
that
same
case, you
thing.
can't have any IVF center in Delhi.
Yes.
Yeah. So we have dealt with the medical legal aspects, little bit into the clinical aspect. So clinicians also will be able to answer. It's not moving. Okay. Yeah, next slide. So coming to the, before going to the clinical aspects, what is the criteria? Maybe Madam Anuradha Madam can tell. Can a couple whose one partner age is 56, husband is 56 but wife is 41, can they undergo IVF?
No, because husband is 56. He has to be less than 55.
Yeah. So wife is just 50. Already, I think criteria
She's
is
already
already.
completed 50. No, you can't.
Okay. Couple has already had an embryo frozen, and she wants the embryo transfer after 50th birthday.
I think if you have done the treatment before 50th birthday,
I think that, yeah, sir will tell. It is
You
not
can't do
allowed.
it. ART procedure means to put the embryo back into the female genital system. So on the day of putting it back into the system, she has to be less than 50.
maybe
And
you can do
husband
a
should be less than 55.
preterm delivery.
No,
Pardon?
it is embryo transfer day.
Embryo
On
transfer.
Embryo transfer
ART
day.
procedure is putting the embryo back.
Correct. So you mean 9 months before her 50th birthday?
No,
Is that what you're saying?
it's the embryo transfer day.
Delivery
will be-
can happen anytime. You can put it 1 minute before 50th birthday.
That's what, yeah. So she can go through that.
Yeah. Young girl at 20 years, AMH is 0.9 after bilateral dermocystectomy. Can we do IUI or IVF if she's already married? She's married, 20 years with 0.9 AMH. They have come to you for IVF. It's not possible.
No.
Yeah, thank you.
23, no?
So this is the age limit that we have to keep in mind. And for commissioning couple, we know very well. For surrogacy, women is 23 to 50, man is 26 to 55. And surrogate mother is 25 to 35. Single mother 21 to 50 years. And a single woman can have surrogacy only when she reaches 35 to 45 years. Is it correct, sir?
Yes, and she has to be widow or ever married. She has to be widow or divorced.
Divorced.
For surrogacy.
Okay. there's
Women
the-
seeking
okay.
surrogacy.
Single
Not a
woman
single
cannot
woman
have.
cannot
Single
have-
woman cannot. If single woman wants it, she has to first marry somebody. Then she has to either kill him or divorce him.
Yes. Yeah. Next slide. So clinical perspective of IUI and IVF. So which one is the, up to what age clinically, Renuka doctor and Anuradha doctor, up to what age you will proceed with IUI in your clinics? Whatever age a patient asks, you will be doing, or you have a cutoff in your center?
I mean, it says up to age 50. That's the limit. If they get
Clinically-
married at
clinically.
49, I'll probably do one cycle of IUI.
Okay.
I won't say test them for IVF.
Okay. Do you have a cutoff, like say, after 38, I counsel
I
them
don't
next?
think age is a cutoff for me. If it's a short-term marriage or something like that, we will try IUI.
Whatever
And
age it is, you will try, give a try for IUI.
IUI, if they are suitable for IUI, that is.
Okay. Next slide. So there was, I went to EV Spain and there was a big board in the front where it mentioned that we don't do IUI after 38 years. Your success
I'm
rate is less
surprised there
than
were boards.
5%.
I'm surprised there were boards like that in Europe.
Yeah, they had mentioned like that. So apart from age, what is the criteria? You take into account any other criteria like AMH? You counsel the patient at AMH of less than 1, there is low success rate with IUI, or you don't counsel them when you see a patient with AMH low? Yeah.
We have to explain them that the time frame what they have for their reproduction is very limited. So there's no point in doing too many cycles of IUI. Their chances may be little lesser, but they still can try a couple of cycles before they get on to IVF.
Yes.
But they need to understand time frame is restricted.
We need to counsel and we need to document it also, because I think there was a case filed by a patient where she was telling that nobody told me that the AMI is low and they kept trying IUI for a long time, and I was not advised IVF by the doctor whom I was getting treatment.
Correct, yeah.
So
They need
it
to
is important that we have to document also. Next slide. So depending, do you counsel the patient the IUI success rate at all? Do you counsel for IVF the success rate, IUI the success rate? Document in the case sheet that this much only is the success rate for the patient. Okay then. So this is how it goes. Yeah, that's next slide also. So how many cycles IUI you do in your practice?
Earlier days, we used to go even up to 6 cycles of IUI. But now there are many couples who don't want to go beyond 2 or 3 cycles of IUI. So it's not that you have to stop at 3, but then you have to look at their age, I mean their image, and what their wishes are like. But usually 2 to 3 cycles.
Yourself, madam, how many cycles do you do?
Yeah, 2 to 3 cycles normally, and then you start counseling them for the higher end treatment after that. If they agree, fine. Otherwise, if they demand IUI, then continue as long as they can do it. And they don't move. But keep counseling them at every step, saying that, this is not working for you, so you need to up your treatment.
To embryologist, what is the minimum count and motility for IUI do you expect? IUI samples.
Definitely, it has an impact because the total motile sperm count should be, greater than 5. But then, both doctors had mentioned about the clinician's perspective, but from an embryologist point of view, I feel that it's not worth doing IUI after 38 years because, even in younger patients, less than 25, though we say that the success rate in IUI is between 12 to 15%, I've never seen, and I'm talking about, 20,000, 30,000 cycles analysis, and what we see is 8 to 10%. Okay, and when you just segregate it by age, then the age above 35, right, especially in Indian women, the success rate is much, much lower. And because of that, there is a very high dropout rate. So what happens is patient will come to an IVF center and they will do IUI first, and the first attempt when it becomes negative, they think that it's a bad this thing, and then the same thing they might do in another place or they will go for IVF in another place. So I feel that taking into all this into consideration, I think patients should be advised IVF if the age is above 35, and the sperm count also matters there.
Does morphology plays major role in IUI success rate?
It does.
Because what I see, they all see the count, let's say 80 million, 90 million, and they recommend for IUI.
So we are talking about 5 million motile normal sperm. That is what we are talking about.
Okay.
Total, that is the total insemination concentration. But then literature also says with 2 million 100% motile normal sperm also there are pregnancies, but below that the success rate is abysmally low.
Anybody does double IUI, like evening one, morning one?
No. Nowadays become all one IUI only.
Okay, so double IUI is not working.
Next day.
We have seen that in double IUI, especially for patients who have not ruptured follicles, whose count is low on the first day, maybe second day, they can come fresh and give another sample. Or if they are coming for a 4th sitting of IUI, those patients, double IUI has worked. And our double IUI, whatever we have done for patients, little patients, few numbers, is having double the success rate of single IUI. Maybe they are doing it for a patient who has ruptured follicles in correct time, and we are doing it in that way. But double IUI is not for all, but for a particular group of patients where low sperm count or oocyte is not ruptured, or they are coming for 4th cycle, then you can do a double IUI and try.
It's a major question for everybody. ICSI for all, for clinicians and embryologists for all? Common question.
ICSI or IVF?
I
It's
work
ICSI.
for an organization where we do ICSI for all. So ICSI for all.
I think in Indian scenario, it has to be ICSI for all because patients, they're all paid patients, You're not going to wait for failed fertilization to start again doing the IVF all over again because it comes out of their pocket. Unlike in Western countries where the government pays for 2 or 3 cycles. So IVF is 50%, more than 50, 60%, 70% is IVF there. I think we can't take that risk.
But most of the patients are so well educated, they know that with ICSI, the risks of abnormalities are a little more developmental. So we need to give a choice to the patient also, talk about it rather than doing ICSI for all. I think it's a patient choice.
How many
also. It
patients do
depends
you
on
do
what-
IVF in your center, madam?
Sorry?
Do you do IVF in your center for your patients?
IVF for some of them, not all of them. I think
10%.
95% of the patients or more than that, they go through ICSI, depending on what we tell them and what they really want. Because there are some who says, no, I don't want to go through ICSI. Because they're so aware
Yeah,
about
yeah.
the abnormalities and all that. So some do say they want to go for IVF. Then it's not that we just do ICSI for everyone, we talk to them.
I would love to hear from Swami, sir. Sir.
Sir, Hitesh, support.
So I have a freedom of whatever I want to fertilize the oocytes. So I do sensibly. So see, doing IVF is little difficult. I say you have to be very, very careful in the sperm preparation. Till now, for IVF, I do my sperm preparation. I will not allow my junior to do. I do it as a passion. I will continue to do.
What I want to add is when you write treatment for the patient, don't write a ICSI or IVF. As a clinician, what you have to write is whose sperm, whose oocyte. ICSI and IVF is a laboratory procedure. For patient, what matters is whose sperm and whose oocyte. Even if you want to write ICSI, you write self oocyte, ICSI with husband sperm. That is how you write. Because just by writing ICSI, you are not specifying what oocytes and what sperm you are going to use, or whose sperm and whose oocytes you are going to use.
Dr. Sujata, if we given a freedom of choosing ICSI or IVF, what will you do for a patient who's having normal parameters, sperm male parameters?
From whatever I've been seeing, like I was telling you, we handle kind of 160 embryologists in our system. So with the kind of experience and with the kind of training with which they come, I feel that, that art of doing IVF is slowly lost. It's very, embryologists do not have that kind of an experience to identify the sperm or to prepare the sperm or to, adjust the concentration of the sperm where your IVF success rate is good. And considering that, I would not take a chance because, like one bacterial contamination there, the entire this thing will get washed out.
Yeah.
So considering that, I would still prefer ICSI.
So you favor ICSI by your heart also.
Yes.
Yes, thank you.
I have a basic question. What about the fertilization, blastocyst conversion, pregnancy rates in IVF versus ICSI in your own experience? Is it same or different?
Like say earlier when we were comparing it with IVF and ICSI, we felt that the blastulation rate was slightly lower in IVF, maybe because of all this sperm we are adding, and that time it was long insemination, meaning that overnight insemination. And so that many sperm, active sperm and cumulus cells, ROS, and maybe because of that, the blastocyst quality was not,
And those ages, blastocyst was not created, I think. It was mostly cleavage
Yes.
when we're doing IVF.
Yes.
Now with ICSI only, we are able to see blast rates.
Yeah, so
very well.
you see a lot of fragmentation and things, but you can never compare pregnancy because you don't. It's the same patient, right? Like so, you cannot compare pregnancy rate, but the blastocyst quality was definitely better than in ICSI than IVF.
Particularly with the international tourism becoming high, I had last month 3 patients consecutively every week asking me that I wanted IVF for my embryos because in IVF I got more embryos than ICSI. So when we had to do 50% of oocytes with IVF, 50% with ICSI, for those patients we got better embryos with IVF, and she even conceived with IVF. So I think we should have little bit of patience to at least listen to them what they want, and not for all, at least for 5 to 10% we should do IVF.
So if the sperm count is excellent and if you feel that, it's a clean sample, more than the count motility morphology, if it is without much of a debris or other contaminants, then even, even we advise in our lab to do 3/4 ICSI and 1/4 IVF. We
Yeah,
do that.
that
And
can
when
be
the
done.
number of oocytes are more, then also to reduce the workload of embryologists, we do advise, but it's never all ICSI.
Yeah.
So I think
All IVF.
IVF, sorry.
All IVF. Yeah.
the first scenario we have discussed already about IUI enough. And second scenario is patient have gone for 2 IVF FET failed cycles. One is day 3 embryo transfer failed. Second, day 5 embryo transfer, 4BC, 4CC failed. What do you recommend? And third question is for azoospermia.
So the scenario 2 we can answer, I think,
Yes,
from the clinician side.
clinician side.
So patient has had 2 IVF and 2 embryo transfers, both of them are negative, what will you advise to the patient? Will you advise some more IVF cycles, or will you choose any other methods?
Patient is a poor responder and she's having endometriosis as well. Anybody
Madam?
can.
Anybody can tell, yeah.
I mean, is she not conceiving because of the poor response, or is it because of endometriosis? So maybe if she has endometriosis, she may need to be treated with medical treatment or surgical, whatever, before the next IVF cycle. And because she is developing embryos, maybe you have to think of pooling the embryos and going for PGT could be the next option.
And
Yes.
they-
Or a donor oocyte has to be suggested.
about the grading part, any embryologist.
Yeah, because the quality is not good. Yeah.
So
But one,
yeah, one may looking for BC. So like you have suggested, pull-up cycles with, if require PGTA, we can try transferring euploid embryos. And if still no pregnancy, ma'am,
Then donor oocyte is one of the options that is always given. She told that.
the last one you asked.
To Dr. Hitesh, difficulties of synchronizing donor embryo transfers. I think by law there is a clause that we have to do fresh embryo transfer for surrogates and for
For donor embryo
There's
transfer.
no law like that.
What they have mentioned is that nobody can freeze the gametes or embryos for surrogacy purpose. That is however they have said that for medical indications you can always freeze the embryos. That also they have mentioned.
Okay.
And so if you want to match the cycle or there is some problem, then you can freeze for medical indication. But you cannot freeze with the intention to do surrogacy. That is what they have said.
So azoospermia patients, how do you manage? I think protocol is clearly written, madam.
do you do synchronized on the day of pickup mostly, or you do a elective TISA or micro TC and then do the pickup? How do you do it in your center?
First, we probably do some hormones and see,
Yeah.
the FSH and the testosterone and all that.
So
and
you
then we'll
differenti-
counsel them. Yes, I would do a pre-TISA first before, not on the day, definitely not on the day of the pickup. A trial TISA has to be done to confirm the presence of the sperms or not. And if you get, you freeze it. And then you can use that for this thing. If no sperms on the day of OPU, you have written donor sperms or oocyte vitrification, I think
Which one do you prefer?
I would prefer oocyte vitrification because you can't counsel the patient on the table. That's not fair.
So it's an important point to be noted. So on table patient should not be counseled for donor sperm if there is no sperms. Trial TISA is recommended.
But if you are going to do a synchronized pickup and TISA, there is already a consent form which is available with all the 3 options. Patient has to choose one and then only go ahead. See, she cannot come on get anesthesia done without choosing one of the option, right?
So there is no form in ART Act as such, but in old ICMR it was there, and we still ask all the consultants to maintain that form, that is Form I, where it is very clearly mentioned whose sperm and whose oocyte. So in such cases, you just tick both husband sperm as well as donor sperm. You take the signature, and in your plan of action also you write ovum pickup followed by ICSI with husband sperm by TESA if not found donor sperm. You write that, and then you can go ahead and do it.
Okay, this is very basic, quick questions. 30 seconds for answers. So can a gynecologist doctor without ART level 1
Already.
wanting to do IUI at your center, would you allow? Legally, she doesn't have a registration.
Gynecologist who is coming to your center for pickup at level 2,
IUI, sir.
for
IUI
IUI also he should have experience of 10 IUIs. If he has that experience, then you can allow.
Okay. Can gynecologists with level 1 ART registration stimulate the patient sent
We
till
have
I
already
think
discussed, I
level
think.
2? I think it's already discussed.
Yeah.
Can a satellite centers unregistered in ART send patient for IUI or IVF to ART clinics?
That is also allowed. As
See,
per
the point is there is nothing like satellite center. Each center is
It's
a separate
It's a
center.
quick question, yes, no only.
So yes, patient can be
Yes.
sent.
So can we do sperm preparation outside in one lab and do IUI in another lab?
Yes.
it is not allowed, no, sir.
Sperm.
It is like-
sperm
Sperm
prepared
preparation.
outside. No,
Yes, yes.
sperm. Then how will you
So it's
shift
a no.
How will you shift the gamete? You can't shift.
in tube.
Yeah,
Some does in
previously
a
it
tube.
was being done.
It was being done. You
Usually
can't do that.
they prepare it outside and then bring the sample.
can't
Now
do
it's
that.
not allowed.
You can't do that.
So can single women go for IVF cycles?
Yes. Yes.
IVF?
Yes.
Yes,
IVF.
Single
yes.
women,
I think
Single
I
woman
answered
can
already.
take treatment. Yes.
So already, what about single men?
Single man, what he will do?
so before divorce it is not allowed, but after divorce for a single woman we can do IVF. Single woman. Before divorce,
It is for surrogacy. For self cycle, she can, even unmarried girl can undergo.
but before divorce, if she has applied for divorce and asking for IVF,
Apply for divorce is married.
yeah. Okay. We'll skip it, I think.
Yeah. So we'll go. What about the ART bank 7 egg rule?
It is 7,
It is 7.
not more than 7.
Not more than. What about the embryologist view on this? Only 7 eggs for ICSI.
Law is same for all. Whether it is embryologist, 8 years jail.
Scientifically.
Whosoever takes more.
Scientifically, madam, you can take this.
What are we
I
going to
just
do with
want to
all
know,
the
sir-
cancellations that has
Sir,
been happening?
from Dr. Hitesh, I just want to know, is it 7 embryos or 7 eggs?
7 oocytes.
That too, not 7 matured oocytes. It's 7 retrieved oocytes. It is 7 oocytes.
So if you get more, discard remaining and just do
No,
ICSI
freeze.
for
You
7.
can freeze the oocytes. That's the thing, right, sir?
If you get more oocytes, sir, let's say 15 oocytes.
You have to aspirate all the follicles but retrieve only 7 oocyte. That is what the law says.
Sir,
No,
what
you have to throw. You have to use only 7. Aspirate all for treatment purpose.
sir,
7 good, yes, you can choose. If it is 40, you can choose good 7. No
sir,
problem.
on that day we are doing 7. So what if the patient fails? Can we freeze those oocytes and use for same lady later?
From 7, you can freeze. Not beyond 7. 7 means 7 in law. It is 1, 2, 3, 4, 5, 6, 7. That's it. It ends there.
So if patient fails in the same OD cycle, and can we stimulate same donor for this? Because
If you intend to go to jail for 8 years, same donor you can't use only once in lifetime.
for the same recipient.
For the same recipient also, the donor has to be changed.
So donor is once in a lifetime.
Once in lifetime. Female can donate only once in lifetime.
For a sperm donor, is there
He
any...
can donate as many times as he
And the
wants.
same sperm donors can be changed for a recipient couple, so any number of times. For a single cycle, same semen sample.
Same sample. Once the sample is given, that has to be used for one couple.
Okay.
So should success rates be made publicly available?
How truthful is
Yes.
that going to be? I don't know. It can be made publicly
legal?
available.
It is legal always.
So I remember like 7, 8 years back, they will put 100% success rate, 100%
That's
IVF
precisely the
success.
point.
That is, whatever they have done is legal, but whatever data they have given is fraudulent.
But how do we know, sir?
Because 100% can't be achieved by science in any system.
So, you see, the thing is, we should have something like the SART data where they will verify the process and then you can enter it. So, you know, they're not in advertisements, but there should be some form of registry where it should be verifiable.
Many Western countries, in their website, if you go and see, they will put the live data of whatever has happened. EV Spain is one of the things which we had been following. Every month we can see what is their pregnancy rate, and they put it very validated report. Yeah.
Yes.
So I would like to wind up with this last question. So as a clinician, what do you expect from embryologist, and as a clinician, what do you expect from medical advisor? This is a real dialogue, the purpose of this whole panel. Or embryologist to clinician.
Yeah.
You can
So,
question.
embryologist to a clinician.
Yes.
See, approach things, especially negative things, in a very scientific way. Because, you know, just go by facts and go by whatever is there. Instead of saying, like, I don't trust that embryologist, you know, we cannot measure, quantify trust. You know, that is a very subjective thing. And no action can be taken. So I feel that this embryologist is favoring that clinician, not me. So these kind of things should be avoided. And I think, especially when there are negative things, more scientifically it has to be approached.
What?
Yes.
Exactly, I also agree. Like, no, we will speak a language of science. There is no, kind of ego issues there. we talk with data, be transparent. That's all. It's very simple.
To medical advisor from clinician or from embryologist. Any questions?
Total transparency is what's happening in the lab. Definitely maintain the quality in the lab. Give us, feedbacks as to what you want from us. And similarly, it's a two-way thing.
Okay. Transparency. You expect transparency from embryologist.
Clinician also and
Clinician.
also embryologist. Yeah, both
Okay.
of them. Yeah.
And also good blast.
Most important thing, anybody should tell everybody the one thing, what genetic material has to be used in this cycle. Please be very clear on genetic, because whatever cases I am facing now and in entire world are not based on day of embryo or the protocol or AMH levels. They are white couple having black child, black couple having white child, A positive couple having B positive child, B positive couple having A positive child, tall couple having short child. These are the cases I am facing in India also. There are 8 cases at hand. These are all related to genetics. Be clear on that. Not a single case I have found why ICSI was not done and why IVF was done. That type of why day 2 transfer was done and why day 5 was not done. No such case ever has happened in the world.
Okay. So with that question, we'll wind up. And thank you,
Excuse me.
all the panelists.
Excuse me, sir.
Yes.
Sir, I have a doubt.
Yes. Yes.
Sir, my question is to Dr. Hitesh. Sir, you told like a gynecologist requires 10 IUI procedures to be qualified to perform a procedure. So what is the legal document to say that a doctor has performed 10 IUIs?
Very good question. See, if similarly 50 pickups are required for gynecologists to qualify. So various appropriate authorities adopt various methods. Some appropriate authorities says you give self-affidavit that I have done 50 pickup. Some appropriate authorities are telling go to your teacher and get a letter that you have done 50 pickup. Some people say that you show me the logbook which you have maintained. So they have to satisfy themselves by various methods. So it is up to your appropriate authority what he demands. But when you call somebody at your center, I always say that you at least take affidavit from that doctor that I am Dr. So-and-so, I have done 10 pickups or I have done 10 IUI or 50 pickups and I am having 3 years post-PG experience in ART. All this information is true and I am aware about the ART Act. That much affidavit you have to take, at least you are safe.
Okay. Thank you, sir. And one more thing, sorry, I have missed during your talk. You said that ICSI followed by something should be written.
Husband sperm
Husband's sperm.
or donor sperm.
Okay. Yeah.
Genetic material has to be specified. Don't write self-ICSI. You can't put oocyte on oocyte. Self means me in law, understand that.
Right.
Husband is a different entity.
Right.
Right? So you have to write very clearly.
Thank you, sir. Thank you.
So thank you, esteemed panelists, for the wonderful suggestions. I think we are all here to give a message that the medico-legal aspects have to be kept in mind. There is no deviation that is allowed in medico-legal aspect. But we should do this IVF work with compassion and not losing the real idea of why we became doctor and embryologist, but still be motivated to use the law in a good direction and not to criticize it. And I think India is moving towards the direction of having legal procedures, documentations, registrations. We should use it in a nice way and grow up with the business and having a clinician's mind. Thank you.
Thank you.
Thank you. What do you call that? The memento. The memento we have to. Memento you've got? Ma'am, there is a memento to collect this. Please stay for a minute. And you give to everybody. Let madam give. I would request I will request this way also. Faisal Sayed. Madam, ask madam. What to say?
I request Aruna ma'am to felicitate Dr. Renuka ma'am. Audience, please join your hands.
I would request Faizullah Sayed to stage.
I request Shamsher Ali sir to felicitate Dr. Swaminathan sir. I request Shamsher Ali sir to felicitate Faizullah Syed.
Sir, I request Swami sir to felicitate Shamsher sir. Come, please come. And also give gift hamper to him, sir. తొందరరా. Sir, Shivanand sir, Rashekar sir, can you please come onto the stage once? Sir, Hitesh Bhatt sir, can you please felicitate Rashekar sir? ఏది
Meanwhile, we'll keep it ready for hands-on workshop. Whoever have give it fast. Next is Shivana. Clap, man, clap. Next is Miss Shweta, madam.
I request Sujata ma'am to felicitate Dr. Shivanand. Dr. Sujata ma'am, please felicitate Mr. Balakumaran.
Meanwhile, faculties, please start your hands-on session. Respective participant, please go to stage. Your hands-on session, nearby hands-on session area. Company people, you also
I would